Greetings. Thank you for the opportunity to cover this topic, atopic dermatitis in skin of color. We've come to accept that there is a high prevalence of atopic dermatitis in all countries worldwide, and that this increasing trend has been going on at least in the last 10 years, and this is across the board, meaning most countries. This slide is meant to illustrate the fact that the prevalence is high in roundabout most countries of the world. Population-based studies that have been conducted in the US have shown a high prevalence of atopic dermatitis in Black children with a point estimate of about 19.3 compared to European American children where the point estimate is about 16. Now, rough estimates that have come from Africa, particularly in children who live in Morocco, South Africa, Kenya, and Nigeria, have also indicated a high prevalence of this condition ranging between 16 and 21%. And yet another study that was conducted in England, particularly studying Black Caribbean school-going children who are London-born, these particular investigators also indicated a high prevalence of atopic dermatitis in these Black Caribbean school-going children compared to their white, Indian, and Pakistani counterparts. So at this stage, it suffices to say that we do not know the exact prevalence of atopic dermatitis in different races, but it seems that although atopic dermatitis is highly prevalent worldwide, some races are more prone to developing this disease than others. Now, we also have come to accept that atopic dermatitis is no single disease, but that it's a complex condition that is a result of an interplay between a number of factors that include genetic predisposition, immune dysregulation, skin barrier dysfunction, as well as environmental factors. When it comes to the genes, the skin barrier genes that have been implicated associating with this condition, the ones that have been widely studied are the filaggrin loss of function gene mutations. So these are the widely studied mutations that associate atopic dermatitis with, it's a genetic link between atopic dermatitis and these filaggrin loss of function mutations. Now, these have been noted particularly in across ethnic groups, but in people of African ancestry, we've found that this association is not clearly defined. A separate study conducted in the US looking for the frequency of these mutations, filaggrin loss of function mutations, documented that they were 6 times less common in African Americans compared to European Americans. Now, a number of investigators in different parts of the world, including here in my country, South Africa, have found no association whatsoever. So the role of filaggrin loss of function mutations in patients of African ancestry seems to be still, there's a need for it to be elucidated still. So in other words, we still don't understand the role at all. We think that there may not be any, but it is yet to be studied further. Now, when it comes to immune related genes, it is thought that it's polymorphisms in genes that are involved in both the innate and the adaptive immunity, particularly in those that are involved in the Th2 signaling pathways implicated in the pathogenesis of atopic dermatitis. They seem to appear to differ. They appear to differ amongst ethnic groups, and I'm referring to polymorphisms in the Th2 related genes, in particular IL-3, IL-4, IL-13, IL-31, and their receptors. And these polymorphisms have been found to associate with increased risk of atopic dermatitis, and it's thought to be due to alterations in signal transduction pathways. Now, in all AD patients, there is a strong Th2 activation or helper T cell activation, but it's also been documented that in Black patients, they seem to have a high IgE serum levels and absent Th17 and Th1 activation. Now, the diagnosis of atopic dermatitis in children with dark skin can pose a particular challenge given the very clinical presentation, particularly across skin types. Now, we expect atopic dermatitis to appear as pruritic erythematous plugs with fine overlying scale, which develop on the flexor surfaces, particularly on the back of the neck, antecubital fossa, popliteal fossa. But in Asian patients, it's been well documented that they present with a lot more different type of lesions. They are well demarcated lesions. They have highs, they've got increased scaling, and they tend to be lichenified. And this is in Asian patients compared to whites. In African patients, the flexural type of morphology in terms of atopic dermatitis presentation seems not to be common. They tend to present more with the extensor involvement, and it's the extensor involvement that is more prominent, as is being shown in this particular picture, particularly the top picture. Now, in addition to the extensor involvement in atopic dermatitis patients of African descent, they also present with this form, which is the follicular type, where they present with these dense aggregated perifollicular accentuated papules that also present on the extensors, on the trunk, and they seem to be more common in dark-skinned individuals than anywhere else. A study in Nigeria showed in their cohorts the prevalence of this particular type of AD to be as high as 54% in that particular study. In addition, patients with, the patients who we are talking about today tend to present with this lichen planus-like atopic dermatitis. And this is seemingly observed exclusively in dark-skinned individuals. And yet again, tend to present on the extensor surfaces, lacks lichenification, but responds rapidly to treatment. Now, even even in patients where the distribution is typical, morphology of lesions appear to differ, and this is based on skin color, it seems. Now, erythema in dark-skinned individuals is more likely to appear violaceous, as I'm trying to show in this particular picture. And because it tends to be more violaceous, it gets missed completely, can be missed completely, particularly with the use of the scores that we are currently using, current severity scores that we've tended to rely on, and that is the SCORAD, the NES, the EASY score. It is thought that these severity scores dramatically underestimate the severity of atopic dermatitis in dark-skinned individuals. But even after adjusting for the erythema score, Black children have been documented to have 6 times higher risk of severe atopic dermatitis than their white counterparts. And this, I'm trying to illustrate that by just showing the type of patient I look after here in South Africa. This is a patient with very severe atopic dermatitis at a very young age. But in addition to that, they tend to have more lichenification than the other, the non-dark-skinned individuals. And they also, the other type that is a lot more common as a classic, one of the classic findings, it's the prurigo type of atopic dermatitis. In addition, they have dry skin, diffuse dry skin, as is being shown in this particular slide. And of course, periorbital dark circles, that is yet again common in the dark-skinned individuals. Now, beyond the differences in the clinical presentation, it appears that atopic dermatitis may also be distinct molecularly or even histologically in certain ethnic groups. In a study comparing white and Asian atopic dermatitis patients, these patients were from Korea and Japan. Asian patients showed a high, increased epidermal hyperplasia. I'm trying to show that in the block C of the picture here. Increased epidermal hyperplasia, which is basically epidermal thickness. And then in addition, they tended to have a frequent parakeratosis, which was yet another histological feature uncommon in other skin types. Now, these histological features were yet again associated with similar Th2 activation as we expect in atopic dermatitis patients in general, but they seem to have a significantly, there seemed to be a significantly increased gene expression of Th17 and Th22 related markers. Now, overall, it looks like the Asian phenotype resembles a mixture of European atopic dermatitis and European psoriasis. And this is based on the profiles that are seen on the molecular and cellular levels. Now, these data are of therapeutic relevance because it means that in addition to targeting the Th2 pathway when you're treating patients of Asian descent, approaches that target the Th17 and even the IL-3 axis may provide some benefits in Asian patients. It's just a slide to show that their histology is distinct, and I've already alluded to that. Now, the current recommendations of treatment in AD are similar across ethnic groups, except for minor nuances due to differences in the skin phenotypes that have already cultural practices. Specifically, it is prudent to consider that the use of high-potency topical corticosteroids can cause hypopigmentation in the darker skin types. And in those, with those physicians who use phototherapy, in particular narrowband UVB, patients of pigmented skin types may require higher doses than the others. Patients with skin of color can present with more resistant, treatment-resistant atopic dermatitis that are not of skin of color. Now, one other consideration to be borne in mind in treating such patients is the cultural consideration, cultural practices that may be in vogue in that particular population. So we've come to accept that prevalence of atopic dermatitis in different races remains unknown, but it does look like some races are more prone to this disease than others. And we also are accepting that atopic dermatitis is clinically a heterogeneous disorder, but we should also bear in mind that it may very well be a genetically heterogeneous one. The role of filaggrin loss of function mutations linked with atopic dermatitis in patients of skin of color is yet to be clarified. We might have to come up with alternative severity scoring systems in atopic dermatitis in patients of color, seeing that the current severity scores, such as the SCORAD and the NES and the EASY scores, may very well miss the severity and may underestimate the severity and may even miss the diagnosis completely. When thinking of therapeutic options in such patients, it is prudent to consider cultural differences that may play a role in the effect of whatever you are prescribing. Thank you very much.